So we'll go ahead and start with the disclosure statement. No disclosures to be made. We do not have a financial arrangement related to the content of this activity. The topic for today is the trans-theoretical model of change, which we'll call the stages of change to avoid the mouthful, and the spirit of MI, motivational interviewing. All right. So we'll start out with objectives. First of all, we want you to be able to identify the core concepts of the trans-theoretical model of change and the specific components of the stages of change in order to apply these concepts to assessment and treatment. We would want you to be able to develop an understanding of the origin and evolution of MI and apply it to present-day case conceptualization and treatment planning. And we'd like you to be able to identify the guiding principles of MI and its basic components as they apply across clinical settings. So we'll start with the stages of change model. What it is, an evidence-based model to match where a person is at with what they need in order to benefit from treatment. So we're going to talk a lot about how stages link up with interventions. The stages of change model is, this surprises a lot of people, not actually a part of motivational interviewing. They go together so often people assume that they're part of a set, but that's because they're so complementary. It can be utilized with MI, and it's an excellent guide for assessing what type of MI intervention is going to help most depending on what stage of the model of change the person is in. So we're going to start with a big picture of the stages of change, and then we'll dive a little more deeply into each component. The main thing I want you to take away from looking at this model is that even though we see the little arrows between all the stages and it looks like they're kind of in this orderly fashion, they are not linear. And this is something that the developers of the model of the change always really want to stress. People can drop in, they can enter and exit in the stages of change at any juncture. And most importantly, it's not a one-dimensional model. You see in the middle that upward spiral. And it's very important to emphasize both as you're conceptualizing patients and as you're explaining these stages to them if it's relevant, that even when they're circulating through these stages, every time they do it, they're gaining experience. All of it is a learning opportunity. So a lot of the times I use the metaphor with patients of a spiral staircase where they turn a corner and perhaps they're back at a slip or back at relapse. That doesn't mean that they're back at the ground floor. They're still making their way up that spiral staircase. It's just that we keep re-entering and exiting those stages of change with any type of health behavior. It is very much the normal thing to circulate through them at least a few times. So I'll point out the basic building blocks of stages of change, and then we'll look more deeply at them. Pre-contemplation, what we usually think of as the beginning stage, although again, nonlinear, is where someone has no intention of changing their behavior. Contemplation, aware that a problem is existing, but no commitment to action. In preparation, there's the intention to take action, but not yet actually making the moves, whereas action is where they're actually modifying that behavior. They're starting to exchange the new behavior for an old one. In maintenance, that's where they're actually sustaining that change. So they really are living that new behavior. And then people are very often surprised to find that relapse is built into the model. But there's a very good reason for that, and we'll dive into that shortly. We do want to make sure that relapse is included in the conceptualization of the stages of change because it very much is more the norm than the exception, and it's important for both providers and patients to anticipate that. So again, big picture, this is nonlinear and it's an upward spiral. So let's dive into the details of what that looks like. The identifying characteristics of each stage of change and pre-contemplation, again, simply not considering change at this time. Contemplation, considering change in the foreseeable future, but not ready to commit to it, doesn't have that intention. Preparation, planning on change in the immediate future. This is really kind of on the precipice, on the cusp of change, but still in the stage where they're kind of thinking it through rather than acting on it. Action, making the moves, making meaningful changes. And then maintenance, that's where you're actually putting that change into effect for a significant period of time. And of course, number 6, relapse, where there's a return to the prior behaviors. And as I mentioned, an important learning opportunity. So let's look at these a little bit more deeply. One of the most important parts of sort of pairing the stages of change with MI or with any intervention approach is making sure you're selecting the strategy that matches the stages of change. Because if you choose the wrong one, if it's incompatible with the stage, it's not just that it won't be helpful. Sometimes you can actually send them back into an earlier stage of change, cause them to sort of escalate to the status quo. So in pre-contemplation, the most important intervention you can do is rapport and alliance building. You're really not trying to push at this stage because as noted, there's not much evident motivation for change. At most, you'd use a very kind of auxiliary MI intervention. Decisional balancing is the most common one in the early stages, and that's just a fancy way of saying pros and cons. That's a way of, in a non-confrontational sort of approach, sorting through what's working, what's not working. But even that, it's risky. You really want to, in pre-contemplation, focus on building that rapport, because that's the foundation that's going to allow you to make the much bigger moves further down the stages of change ladder. Contemplation is the gold zone for motivational interviewing. This is where people are sort of teetering on that cusp of, I don't know if I want to change, but maybe change would be nice. And motivational interviewing is just an excellent strategy to help them decide and to commit to one side or the other. For preparation, that's more of the sort of planning, the processes of change. So there are MI skills that go along with this, but generally it's more about helping them hone things like SMART goals. It's, how are they going to get to where they want to go? So in preparation, you probably don't want to use much of the standard MI techniques, because they're already on their way, and MI is really focusing on getting that change moving. Similarly, in action, you're focusing on skill building in the process of self-efficacy. So that's, seeing, what are they missing that could help them on their way to success, and supporting them with that. And then with maintenance, of course, there's a strong focus on relapse prevention. How do you help them to keep what they've already accomplished? So that's sort of another dimension of self-efficacy. All right, so with pre-contemplation, looking a little more closely, at this stage, they may not recognize that there's a problem, and they haven't thought in any serious way about changing. So here, again, your goals are really just to bring awareness of the problem to the surface so that the person can start thinking about it. You're not trying to do anything more concrete or actionable than that. And even with bringing awareness to the surface, you want to be pretty subtle, because again, you don't want to push, you really want to preserve that alliance. The alliance building is really about keeping the patient engaged in the process. So there's a lot of reflective listening. You want to elicit more information. So that's that, tell me more about that kind of questions, asking about how it's affected them, how they're feeling about it now, how have they been dealing with it. And then communicating caring, empathy, honesty, and acceptance. And I can't emphasize enough, that rapport building component is absolutely essential throughout all stages, but particularly pre-contemplation. With contemplation, the person is willing to think about making a change, but not yet ready to do something about it. So the goal is to move them towards action in a very gentle and collaborative way. So the main thing here, and if you decide to do an actual training on MA, you'll learn a lot about change talk versus sustain talk. So the idea there is when people talk about the status quo, in a positive way, you just kind of avoid reinforcing it. Whereas when they sort of touch on, well, maybe change would be nice, or I could see how this would work, you keep them talking, you really reinforce that. You want to boost the person's awareness of change options. So that's the kind of, well, perhaps if they haven't thought of this, that, or the other thing that would be useful to them, just bringing it into view rather than kind of foisting it upon them. And also increasing the perceived benefit of change, as always, with their permission. You're drawing on what their own individual perspective is to say, hey, it sounds like this would actually be a lot easier for you if ... One way that we do that is through developing discrepancy. So that's about when they point out things that, their behavior is kind of contradicting what their values and goals are. You just shine a light on that. It's not in an accusatory way. You just kind of say, hey, I notice, you say that this is where you're trying to go, but it looks like you're kind of headed in the other direction. Interesting, let's talk about that. So that's a way of giving feedback that's very non-confrontational and just helping them to clarify their own intentions. When discord arises, this is always a signal to move back to the pre-contemplation strategy of rapport building. Discord is a sign that probably without meaning to at all, you've been trying to argue or trying to persuade, which is very much the natural human inclination. And instead you take a step back, you apologize, affirm, accept, use a lot of reflective listening. You say, what, I was mistaken. I think I moved too fast, or I misunderstood. Let me make sure I understand where you're at. A really seemingly sort of deceptively simple strategy here is, rather than using the phrase yes, but, we use yes, and. Yes, but is sort of this it's more confrontational language. It's sort of perpendicular, whereas yes, and is the coming alongside stance, which characterizes MI. And yes, and helps patients to see two seemingly contradictory things can exist next to each other at the same time. It sort of introduces some nuance and some shades of gray, which is very helpful in the contemplation stage, where often there's the temptation to go kind of black and white thinking. And lastly, supporting self-efficacy. So that's reviewing past successes, really projecting that optimistic stance. I have faith that you can do this, affirming their commitment, and really highlighting their decision-making ability, because when you help people to recognize their autonomy, they're much more likely to act with it in a positive way. All right, action. A person in this stage is ready to make an initial attempt to change behavior, but might not be confident about how to succeed. Our goal here is just to smooth the path for them. We're trying to decrease the barriers to change by encouraging their progress, reducing those barriers, sometimes in a concrete way. And people are sometimes surprised about this, but restraining excessive change to make sure that they succeed. Sometimes people get really ebullient and enthusiastic once they get into the action stage and set goals that are not really realistic for them. So you want to make sure that, that it's plausible what they're aiming for, so that they're set up for success. Relapse, like I said, a really important part to feature as a normal characteristic of the change process. It's the norm rather than the exception. It's not a sign of failure. We really want to normalize that it's part of chronic illness management across all types of health behaviors. Changing behaviors is very difficult, and that's one reason that relapse is part of it. And it's really important to remember as providers that how we talk about relapse can really have a profound effect on the patients that we're working with, because most people have the implicit idea that relapse is failure. So we have to proactively work to correct that. And this is really kind of a paradigm shift for us as providers that we're trying to communicate to patients to say, this is not only normal, this is actually a data gathering experience, right? This is that thing of getting back on the spiral staircase to a place that looks familiar, but you have more information now. This was a learning opportunity. And one of the reasons that we do this, emphasize that learning opportunity part and also predict that relapse is going to happen, is because of what's called the abstinence violation effect. And this is what happens when somebody has been successfully, making movement through the process of change, and then they have a slip or a lapse, and they decide, you know what, all that hard work has gone down the drain. I'm just going to go back to the way things are because of that one slip. And if you can predict this thinking pattern, and also that the relapse or that the lapse will happen in the first place, then you're much more likely to be able to help them be successful by thinking through ahead of time. Well, no, you don't need to go all the way back. In fact, you don't even need to go back to pre-contemplation if you don't want to. There's often this feeling of, I have to go back to square one, that they have the choice of where they're going to re-enter the change process. And they have a lot more information now about what sets them up for success and failure. So the abstinence violation effect, a very important thing to talk about. I often use a phrase that a patient reflected to me with this, which is, don't let a slip become a snowball. And I think that's a great way to describe that idea of, just because you sort of took a little detour off the road, it doesn't mean you have to go to a different destination, right? You can always course correct. With relapse, your goals are to help them avoid becoming discouraged. And again, that's a huge part of the normalization process of, this happens to most people in this process, and then help them re-engage in the change process at a fruitful juncture on their own terms. So we're going to pivot now to the spirit of motivational interviewing. Again, this is not actually a part of the stages of change model, but they're very complementary, so we put them together. This is a quote from Blaise Pascal that does a nice job of summing up the kind of heart of MI, which is, people are generally better persuaded by the reasons which they have themselves discovered than by those which have come into the mind of others. And this really sums up the crux of MI, which is very much about what we can help patients bring forth that is already within them, rather than imposing on them, from our own perspective and our own idea of what's right for them. So what is motivational interviewing? It was created by UNM's own Bill Miller alongside Stephen Rolnick. It's an effective method for talking with people about change, with emphasized because, again, it's very collaborative. It's a person-centered form of guiding to elicit and strengthen motivation for change. In fact, it grows out of person-centered therapy, Rogerian therapy. And it's a clinical method used when a person may benefit from making a behavior or lifestyle change and is reluctant or ambivalent about doing so. So again, that's about matching stage of change to intervention. You really want to catch them at that point where they're sort of teetering between, I think I want it, but I'm not sure. So the research evidence for MI is very strong. We have a couple summaries and meta-analyses here. The 2005 one showed that adding MI at the beginning of treatment was especially helpful for making sure that outcome improvements were sustained on the other side. So really a lot of benefit to getting it in there at the beginning. And if you look at the bottom bullet for that top part, outcomes were better when no manual was used. This is a really interesting finding. This was a very early version of MI back in 2005, where the manual asked the providers to implement a concrete behavior change plan at the end of the session, whether or not the patients asked for it. And now we know this is very much in violation of the spirit of MI. At the time, it was very congruent with the CBT type models that were being done. But obviously, now we know that's actually going to elicit some resistance from the patient. That's what MI is all about, making sure we're not eliciting that resistance. So the practitioners who weren't following the manual actually did better because they were going with just the spirit of NI instead of that technical intervention, which was later discarded. With the second meta-analysis, one of the things that they found was that the effect sizes were largest for outcomes related to weight loss, blood pressure, and substance use. So obviously very impressive areas to be able to get traction, and that it was useful in as few as a single session. So remembering getting in it at the beginning, and even just a little bit of MI can be helpful, even if there isn't somebody there who's trained to provide, or there isn't the time or the opportunity to provide more than that. So in talking about the spirit of MI, we really want to emphasize ambivalence. So in MI, it's not just that we accept that ambivalence happens, we appreciate it. We sort of embrace ambivalence and understand that it's a core part of the change process. Ambivalence, of course, meaning being of two minds about things, having sort of two seemingly contradictory sentiments at once. Very often we mistake ambivalence for lack of motivation. That's often what it looks like, when somebody's not making the moves that it seems like they should. It's not that they don't want to. It's often that there is this kind of internal tug of war, this internal seesaw about, well, is it what I want? This is what I'm already doing is kind of working for me. So the back and forth, recognizing that is important because you don't want to give up on patients when you think they have lack of motivation, nor do you want to reflect that to them. So we think of ambivalence as a normal part of the change process. It's common prior to as well as during habit change. And an important feature of ambivalence is, as providers, we very easily are pulled into what's called the communication trap, which is when we see somebody kind of on the fence, we really want to argue the side that we're obviously going to promote, which is moving them towards more healthy habit. But what we know about human nature is that when somebody takes that one side, then the patient is going to take up the other side. So if we are advocating for the change, they are going to defend the status quo. And the more we argue, the more they escalate to their current position. That's the communication trap around ambivalence. And that goes along with the righting reflex. So righting reflex is this very well-intentioned natural inclination we have to make it better for another person. Who wouldn't want to do that? The danger there is that we're telling the other person what to do, how to do, and why they should do it without actually incorporating their individual point of view and accounting for their circumstances and values and goals. And that creates resistance. We're moving away from that partnering stance of MI and into the expert top-down role, much as I just mentioned with that study, when we say, here, we're going to make a change plan, whether you feel like it's relevant or not. And that's going to create that resistance. So the implicit inceptions behind righting reflex is we think they don't know, they don't see, they don't know how, they don't care. And so we want to give them insight, knowledge, and skills. And that's a great sentiment for later on in the change process. That's great for example, action. But earlier on, it's not going to help. What we really want to do is help them discover what they already have inside and highlight that existing motivation. So a little graphic that shows what happens when the righting reflex meets ambivalence. It's kind of that the immovable object and the irresistible force. And what you're doing when you're exercising the righting reflex is you're accidentally building that muscle of them sort of attaching to the status quo when you try to engage with their ambivalence in that sort of forceful way. So the consequences of the righting reflex, perhaps the patient likes you a lot, so they make a change briefly to try to make you happy, but it's not for their own benefit, so it's not going to stick. Maybe they listen politely and then go ahead and do whatever they were going to do in the first place. They think we've all had many experiences of that. And sometimes the patient protests, and that elicits our own desire to resist. We push harder, and again, we lock horns and get further into that cycle. So no one benefits. It's often even counterproductive. And it's very tempting at this juncture to blame the patient and say, they are not motivated or they are resistant, when in fact we have inadvertently been contributing to getting them into this sort of locked in stance by inducing that resistance. So MI loves their acronyms. RULE is resist the writing reflex, understand your patient's motivation, listen to your patient, and empower your patient. So that's really about moving from that authority stance to that coming alongside stance of who are you, where are you coming from, you know, what is actually going to be helpful for you. The components of MI we represent here as a sort of almost like a hierarchy of needs kind of pyramid. And we do that in order to emphasize that that spirit of MI really is the building block that everything else is built upon. So as I referenced with that study, even if you don't have all of the technical skills in place, as long as you're operating with the spirit of MI, you're probably going to get to a good place. So spirit, that's about acceptance, collaboration, and evocation. I'm going to move through these a little quickly for time. Acceptance is that sort of Rogerian stance of absolute worth. So that's positive, unconditional regard, irrespective of what kind of judgments you're tempted to make about the patient's behavior. And the paradox there is that when people experience being accepted as they are, they're free to change. It involves accurate empathy, making sure you really understand their perspective, meaning, and values, and supporting their autonomy, their ability to make choices, as well as actively affirming your appreciation for their change-making behaviors. So this is in contrast to authority. So we're affirming their right and capacity for self-direction instead of telling them what to do, and honoring their ability to make decisions for themselves, even if they're the decisions that we would not make for them, avoiding that sense of they can't make informed decisions and we need to tell them what to do. Collaboration, again, is just that stance that it's collaboration. It's alongside rather than top down. You're dancing rather than wrestling. It's a process of exploration rather than trying to persuade or coerce somebody towards a particular preconceived notion of what's right for them. So it's conducted for and with a person, and they are the experts on themselves. They know what they need and what to do. You're there to support them with that. So the contrast there is confrontation, where in somewhat anachronistic healthcare models, we're often trained to override the patient's perspective and say, here's what you actually need. We're going to go ahead and impose that on you. Lastly, evocation. That's that idea of you have what you need, together we'll bring it forth, trusting that that motivation and the resources are incipient already in the patient. You don't need to wait until they're nebulously ready. You're working with what they have and where they are, and you're strengthening that motivation that's already present, really capitalizing on their why. So understanding their perspective and wisdom and bringing that to the forefront of the conversation. The contrast there is with education. So you're really enhancing the intrinsic motivation instead of looking at it as a deficit model where you need to sort of input education. So lastly, a graphic that kind of summarizes the difference between those somewhat traditional healthcare model stances, where there's the wrestling, the sort of, I am going to tell you what to do. That's more sort of paternalistic, top down and domination oriented, where you're trying to sort of insert education for the patients, versus this dance where you're collaborative, you're coming alongside, there's the back and forth. And overall, it's a partnership process rather than one in which you're trying to reach, a single outcome on your own terms. And lastly, references. I'll go ahead and unshare here. Are there any questions or any comments on this presentation before we move to the case discussion?